So thank you, Dr. Godwin. And like Dr. Godwin mentioned, we have a multidisciplinary translational team here at UTMB, and with that, we've been doing some qualitative stuff on shared decision making in cancer care. And Dr. Rao recently submitted a P40 grant. We submitted it for the last cycle before that, and got revisions back as to what we could change. So we've made some modifications in our study plan and things that we've done. So I'm just going to present pretty much our methods and then sort of the data we've come up with so far and progress that we're making. So just to start off with, shared decision making is exactly what it sounds. It's when patients, physicians, and caregivers come together to make treatment decisions for patients. And it's a combination of being based on the best available evidence and also in the context of the patient's values and their preferences for treatment. And the two components to shared decision making for physicians, they must have the ability to be able to communicate that core knowledge to patients and then also to clarify and elicit patient preferences. So the two critical components of shared decision making are knowledge and values clarification, and this comes up a lot in the shared decision-making literature, these two kind of concepts. So core knowledge is basically includes having patients understand the nature of the disease, the condition, and then kind of going with consent, understanding exactly what the treatment risks are, the benefits, alternatives to treatment, and then things that we're not certain about in terms of trajectory of care, just by virtue of not having that information. And then values are defined as informed attitudes about treatment options and treatment characteristics. So patients would know exactly what the toxicities of certain treatments are, and then making decisions based on those treatment options, understanding the trade-offs. So for example, chemotherapy is highly toxic, and understanding the quantity of life that you get off of that. So it's making decisions based on that. So this is just kind of a diagram that sort of talks about shared decision making. The real focus is the patient preferences and the physician preferences. So for patient preferences, it's having physicians being able to elicit those preferences from patients, what their goals of treatment are, and then the patient's attitudes toward death, quality of life, quantity of life, and then what their own expectations of treatment are, and then also where they stand in terms of the shared decision-making spectrum. So some patients want to take a more passive role. They prefer that the physician makes the treatment recommendations and decisions for them. And then on the other hand, you have patients who want to be the decision makers. They want to know that they're the ones who made the decision. And the part for the physician is also being able to establish what the goals of treatment are and what we can and cannot do, how aggressive we can be with treatment. But at the same time, understanding exactly what the patient attitudes are towards shared decision making and what role they want to play. So putting that all together, coming to a final medical decision, and then going through treatment, and then it's all sort of a feedback loop. And so shared decision making for cancer care is really, shared decision making is ideal when you have multiple treatment options, just like in cancer care, and a lot of options to choose from for patients. And all these options vary on their impact and long-term survival for patients and then their quality of life. So for chemotherapy, a lot of patients want to understand exactly what that trade-off is. And then ultimately, patients have to be able to understand and evaluate these options in terms of their cancer characteristics and then also their own treatment goals. Looking back at the studies on shared decision making and kind of patients understanding the treatments and their expectations, we're not very good at shared decision making. In New England Journal of Medicine in 2012, there was a prospective observational study that handed out 1,193 surveys to patients who had stage 4 lung cancer or stage 4 colorectal cancer. And patients responded to surveys with questions adapted from the Los Angeles Women's Healthcare Study. And those questions were basically, if you look at the questions, one of the questions is, how likely is it, do you think, that chemotherapy will cure your cancer? And then they check a box from not likely at all to very likely. And a really high percentage of patients had inaccurate expectations of what was going on. 69% of patients with lung cancer, almost 80% of patients with colorectal cancer had inaccurate expectations of what chemotherapy was actually going to do for them and what the curative benefit was. And then also in 2010, there's out of the Annals of Oncology, there's a systematic review, 22 studies of patients with all types of cancer, breast cancer, colorectal cancer, and so on. And all these studies showed a discrepancy between what patients preferred and what their actual or perceived roles were in decision making. And patients actually wanted more of an active role and more of a shared role in their decision making process. And across all types of cancer, they wanted to have more participation in their care. And then they also kind of did a sub-study of that and looked at interventions to sort of improve shared decision making. And they didn't really have, no studies really mention any interventions to sort of match that expectation of treatment with, and what their preferred roles were to what their actual roles were. So our study aims, it's 3 parts. The first is to kind of assess the current standard of the status of cancer patient, caregiver, and physician attitudes and satisfaction with the shared decision-making process. And when we had initially submitted the PCORI grant, we had talked about decision aids and doing things, those types of interventions to help patients make decisions, but they actually really didn't want that kind of thing at all. So we had to go back and revise the grant and came up with AIM 2, which was to perform a randomized controlled trial of audio recording the patient and physician clinical encounter and sort of try to understand how shared decision making takes place and what we can do to improve that. And then finally, the third aim is to put all of this together and sort of explore the preferred patient and stakeholder methods for values clarification and eliciting these preferences during the whole shared decision making process. So I'm primarily going to talk about AIM 1, which is where we are in our study right now with interviewing patients and sort of trying to understand where we are in shared decision making, how patients and physicians alike sort of feel about the whole process. So in the beginning of the set, what I did was I would just go out and interview patients of all types of cancer, all different stages of treatment, and we got a lot of very interesting data, but sort of thought that we had to kind of define our study a little bit better and really target a certain population and what we were trying to achieve, because with all this information, it gets really hard to answer very specific questions. So we kind of narrowed down our aim to only interviewing recently diagnosed patients with metastatic and non-metastatic disease. So we divided up into those 2 groups, and it actually made it a lot cleaner. And then the second thing we did was what's called a cluster view technique. And what that means is that we not only interview the patients, but we also give them self-administered questionnaires. So we start the interview with a questionnaire that's based on valid measures. And what I found was that it's actually really helpful, because some of the questions that are difficult to ask, like from the Los Angeles Women's Health Study, where they say, how likely is it, do you think, that chemotherapy is going to help you live longer? It's not an easy question to ask, but when it's put in a survey format like that, then that becomes a trigger point for more of a conversation, and you get to really understand what patients understand of chemotherapy and what their expectations are. So I found this to be really helpful. And then that's followed by open-ended questions, still the same kind of thing, where we ask patients to just tell us their story and what their experiences are.
So what's the timing on that? I mean, you give them the questionnaire, and then do you wait around while they're answering questions?
Yeah. So I actually timed, and I'll mention that later, but I timed how long it takes them to do the survey. And even that process took a little while, because what we think is easy to just answer is not easy for patients. So I had to modify that quite a few times before I think I came down with something that was pretty easy for everybody across the board.
And after they finish, they give it back to you, and you read it, and then you ask them. Okay.
Yeah, and it just helps facilitate more conversation with them as well. So the validated scales that we use are the choose. So these are the validated measures, and then how many questions they have, and then I time to see about how much time it takes them to answer each one. Altogether, the questionnaires take anywhere from like 13 to 15 minutes for all patients. So it didn't take much time, and it wasn't very awkward just sitting there watching them do it. So it ended up being a nice thing to have. The choose 3-item literacy measure is 3 questions, and basically, they ask, do you constantly have to have help filling out your medical forms? Do you need help reading your forms? And these 3 questions have been proven to really help define health literacy. And then the SF36 is the quality of life. So that's 36 questions, but we basically took 9 questions out of that really elicited depression and mood, because we sort of wanted to correlate that as well. And then the shared decision-making questionnaire, that's a measure that's used for patients, and then it's a dyadic scale, so they have one for physicians as well. Kind of similar questions, and so you can correlate those two things.
Is that preferences or their experience?
For shared decision-making, it's more of their experience. So the questions are basically, did the physician present you with these options?
Yeah, okay, cool.
So that's pretty much what those questions are. And then the control preferences scale is 5, it's a card sort, and it's 5 different cards that show an active role, a collaborative role, and a passive role. And this measure is really good and has been used a lot in shared decision-making literature to elicit how patients see themselves in their encounter with their physicians. And then finally, the decisional conflict scale, it has 3
I'm sorry to interrupt, but is that all, the control preferences is what they want
right.
to happen?
Mm-hmm.
Okay.
Yeah, what they prefer, what role they prefer. And then the decisional conflict scale is, what it is decisional conflict. If they had, if they felt that they understood what the risks were, and if they felt that those risks were in line with what their personal goals and treatment characteristics were.
So it's an internal conflict.
Mm-hmm. And it also kind of reflects if they felt that they were explained the risks of treatment, and if they made that decision for that treatment, knowing the risks, and if it was in line with what they wanted for their own life. So the interview, starting with the open-ended questions, it's basically just talking to the patient. So I put all of my papers away and I just sit down and I talk to them and I just say, tell me about your experience, or how did you get diagnosed, what happened? And oftentimes I find that just leads to an entire story with all sorts of information about, what experiences they've had, and they say a lot more than what you would normally get just by asking directed questions or just by filling out a survey as well. So this gave us a lot of really good information, what concerns did you have, and then they come up with a list of things that's important to them. And then we assess the treatment expectations. So we're using the same questions that they did from the New England Journal of Medicine study from the Los Angeles Women's Health. And so, as I mentioned before, it's, after talking to your doctors, how likely is it you think that chemotherapy or surgery or radiation, either of those, would help you live longer or help cure your cancer? And so that kind of really helped to get that part of the survey, because I felt in the beginning we weren't really answering those questions, but once we started doing it this way, it really helped to elicit that information.
And so you asked about each one that the person had discussed with the physician?
Right.
Did you have patients involved in helping decide, for former patients, the questions you'd be asking, the open-ended questions you'd be asking?
No, so at this stage right now, we're pretty much just getting some of the pilot data, but eventually that is what we want to do, have
Because that's one for Corey. I mean, I went to a session at Academy Health, and that was one of the things they emphasized is engaging the stakeholders
And actually, in our monthly meetings that we do have one patient that does participate, and so there is one patient. I completely forgot about that. But eventually, what we do want to have is a patient-physician advisory committee, and then focus groups, and so that's all part of the plan as well. We just haven't implemented that yet. We're still kind of early on, but we do have a patient in our group. So our target sample size is 40 patients in the metastatic and non-metastatic groups. In qualitative research, they say saturation, which is basically when you don't identify any new themes across patients. That's achieved after about 10 or 12 interviews. But for the quantitative measures, we want about 40 patients in each group. And we've also started to get multi-institutional participation. So I've been talking to people over at Hopkins and at Wisconsin, and they're willing to participate. They're just trying to get their IRB in right now, so I'm helping them with that. But once we get that done, we can go over there and get a lot more data. Those are high-volume centers, and the PCORI grant is targeted towards patients with pancreatic cancer, so those are high-volume pancreatic cancer centers. So we'll be able to get a lot more patients that way as well.
So this is theoretically the saturation would be 10 to 12, not what you found.
Right,
okay.
Right. So the qualitative data, we record all the interviews, and then they get transcribed and put into the in vivo qualitative software and code for emerging themes, which I'll talk about further what themes are, what that means. And then the recurrent themes are summarized, and then they're tabulated across patients. And then for the quantitative data, basically right now we're just getting some kind of demographic summaries and trying to figure out the scores for the scales that we get for each of these patients. So far, I've interviewed 8 physicians of different specialties, and then their years in practice range from 8 months to 33 years. And then I've done 20 patient interviews. 10 of the patient interviews were just the beginning where I pretty much got anyone that I got referral to. So part of the problem was that as part of our IRB, we had to be referred patients. I could not just approach anybody. So, and that has to come from a trusted source. So getting people to be referred to me was actually really, really difficult. But then finally now we have a system in place that I think it's working a lot better. We have a nurse coordinator who helps us over at Victory Lakes. So I've done 10 patient interviews with patients with a range of cancer diagnoses. And then 10 interviews I've done with the use of these scales in the recently diagnosed patients. So this is in the 10 patients who I've interviewed who had the scales. And it's five people in the non-metastatic group and 5 people in the metastatic group. And time to diagnosis was about, we said recently diagnosed was defined as within 6 months of diagnosis, and they could have had any treatment within that time, but within 6 months is when I'm being referred patients. And the age is about 6 years is about average for most patients. And they range from breast cancer, had 1 pancreatic cancer patient, lymphoma, melanoma, and then a wide variety of treatments. Of note, there are no patients who got no treatment, so everybody had some form of treatment.
Well, this is both treatment planned and treatment received.
Exactly, yeah. And so far, the education level is pretty much the same across both groups, and then race is also pretty evenly distributed across income groups. About 4 people out of the 10 are less than 20,000, and then kind of interspersed throughout, sort of the same. And then everybody is covered by insurance. And so this is the information for the scales. So the health literacy, the metastatic group actually pretty much answered the same for every question, which is interesting. But literacy was pretty good across the board. I mean, just watching patients answer these questions and be able to do this, I got the sense that everybody was pretty much able to understand the survey questions and the questions I was asking them as well. The shared decision-making scale, 100% is total satisfaction, and then that's so it's from 0 to 100%. The metastatic group had about a 38% satisfaction in shared decision-making, so that's kind of an interesting finding there. And then the control preferences was the role that patients wanted to play in their care, and that ranged from active to passive. And then for the metastatic group, nobody really wanted a passive role. And then decisional conflict, so decisional conflict is 0 is the best score for saying that, I'm completely satisfied with my decisions. I really don't have any conflict as to the decisions I made. And then 100 is the worst. So the metastatic group actually scored pretty poorly with that. And what's interesting is that the subscale of values 30, which is where you feel that the physician had really understood your preferences and your values, was the thing that was the highest, so the worst score in all of those subscales in predicting, that conflict. So, and that's, I'll show you later on, that becomes kind of important in terms of.
You may get into this with your patients, but has there been much written on? It seems to me that if you've been told you have metastatic disease that doesn't have a cure, you're going to be pissed, and when you're pissed, when someone then comes in and asks a relatively subtle question, they're going to get the pissed response no matter what, and so what they may be saying, and I think there's ways of looking at this, and what they may be saying is, no, of course I didn't like the decision-making process because I wasn't given the option of a cure.
Right. Yeah. And there has been literature written on that, and that's very true. And I think across some of these patients, that's sort of the sense that I got. One patient who she was diagnosed after being misdiagnosed for 2 years, and then she got diagnosed as metastatic. So she was upset, and she even admitted during the interview. She said, I think my experience has just been different, and I'm just angry. So, maybe if I was just diagnosed as metastatic first time around, then I wouldn't have felt this way. But now I'm angry. So that's a very good point, and I think that's very true. And I just want to see, we need to get more interviews, but it would be interesting to see what happens with more people. So recurring themes across patients. So like I mentioned in vivo, I would read through the transcripts and then sort of identify themes that occur consistently across patients. So important things to patients, decision behaviors, the importance of autonomy, treatment for patients in the gray zone, which is basically whether or not chemotherapy was really going to be to their advantage. A fear of recurrence of the cancer was a big concern for most patients. They got confused with a lot of the specialties. And then we also did in the beginning we sort of had this idea where we wanted to understand what the barriers or facilitators were to clinical trial participation for both physicians and patients. So for those, I did ask specific questions about, what do you think a clinical trial is and how do you feel about it? And so there was across the board, though, there was a large misconception of exactly what clinical trials are, and then a need for easy-to-read information. So examples of some of these themes. So for patient autonomy, this patient would say, it was my decision, everybody was there, but I decided what was best for me, basically, is what she had said. So that is an example of that theme of patient autonomy. And then barriers to clinical trial participation. This one patient had said, they make you recite the numbers and it makes you less desirable to go to clinical trials. You can't treat us like data sets. And that was a common thing that was kind of mentioned across patients as well. And then finally, fear of recurrence was something that, when I asked what are your main concerns, fear of recurrence was a big one that kept coming up across patients. So, and specifically this patient said, I think when you finish treatment, there's this worry, is it going to come back? It's huge. I don't think it, I know it. So this chart here is what's called a free listing technique. So what I had asked patients is what characteristic is most important to you in your physician? And then I would just ask them to list it off. And if they said something like compassion, then I would ask them to define, so what does compassion mean to you? And then we get the number of patients that said those specific things. And this really helps to establish, what's culturally relevant to patients and the domains of satisfaction across patients. And I thought this was really interesting. The first one, someone who shows compassion, 9 out of 11 patients had said that, and defined as doesn't sit behind the laptop and reads my chart before they come in. Almost every patient had mentioned those specific things. And then spends time with you. Sitting down was a huge thing. Everybody had said that. And then talking eye to eye. And then as you go down, so we still have more to go. We see we're not completely saturated in all of our themes yet, but I know we've done several interviews, but I think we still have a lot more we need. But as you go down the list, less people mention those specific things. But the top two I thought were really, it's actually pretty fascinating. Everybody said doesn't sit behind the laptop.
So much for the EMR.
Yeah. And then I interviewed 8 physicians, and physician recurring themes were repetition through multiple visits. So not being able to provide all the information in one go, you have to keep bringing patients back to the clinic and discussing with them, their care, and sort of to help them understand the disease process.
So when you say recurring themes, these are positive. These are things that physician were saying this is important for the process?
Or the things that came up across all physicians.
Okay,
Yeah.
it was a topic.
Right,
Okay.
exactly, yeah. And then a multidisciplinary approach. Everybody mentioned tumor board somewhere or the other in their talk of how to manage the patients. And then everybody sort of talked about their initial approach to how they sat down or how they would talk to patients. And then discussing how they discuss treatment options, prognostication, what they thought were patient concerns, and then conflicts between patients, and then they also mentioned some barriers to clinical trial participation. So examples of themes from physician interviews, so repetition through multiple visits. This first one says sometimes at the beginning if you give them too many details about the treatment, they get really confused, and then talks about how they have to keep bringing it back to clinic. Perception of patient concerns. This was by a surgeon who said, chemo can last months and it really wears on you, so I find chemo is very stressful for most patients. And then barriers to clinical trial participation. This oncologist had said there are always patients who are skeptical about trials, trying new drugs. I don't think you can change their mind about that. So I think there's a lot of room for sort of understanding barriers to clinical trial participation, and it would be a nice sub-study of things that we're doing in the future. So this, I know, I for the life of me, I could not figure out how to change the font in NVivo. But I just wanted to give you an idea of sort of how the software works. So once you put all of the information in and you code all of your data, you can get word tree diagrams. So it's basically cluster analysis. And it puts those things that come up often together in some nodes. But what I really wanted to focus on was what came out of that whole thing was that the decision-making process was most highly correlated with patient values and needs, so preferences, and then information gathering, so how they got their information. And these two were they correlated the highest. So I thought that was the two critical parts to shared decision-making was knowledge and preference elicitation, and it was sort of reflected in the data.
Could you say that again? What does information gathering correlate with?
So information gathering correlates with the decision-making process, and patient values and needs correlate with the decision-making process.
Oh.
And so both those things came up as just having the highest correlation.
And what's the decision-making process?
So that was shared decision-making and how patients define shared decision-making. Yeah.
So that was their score on that scale?
That wasn't the score. So this is only for coded interviews. So this is what
okay.
patients had said. So this is across all interviews with patients. It's about 20 patients. And then...
Is this like satisfaction with the decision-making process? Or?
Yeah,
Okay.
satisfaction and ideas of how they came to their decision, but mostly satisfaction with the decision-making process.
So it's like, so patient values correlates with their satisfaction with the decision-making process.
Right.
And then patient what on information gathering? In other words,
So,
patient opinions or whether they got enough or what?
whether they got enough information.
Okay, satisfaction about information.
Right.
Okay.
Yeah. Sorry, this is how the data is coded, just how I write it, but yeah, that's exactly what it is. How they got their information, or whether the information was adequate, and then whether their preferences were met, and how that all is tied in with their satisfaction with shared decision making. So then looking back at the data.
So you could do that, I'm sorry, I mean, you could do that like, getting back to the multivariable, I mean, you could do that just looking at it in terms of how much of the variance in decision-making, satisfaction with decision-making can you explain by all these other things, right?
Right,
Okay.
yeah. And so, as I mentioned in the beginning, shared decision-making, the two critical components are knowledge and preference elicitation. So we have a table here that shows the first component is the knowledge and understanding the information. So and this is kind of the same technique as the patients, 20 patients, and then physicians was the eight physicians. So for 10 out of the 20 patients, so 50% of patients said that their written information was too detailed. And so examples of this theme was that, things in writing always help, but too much paper gets to be a whole lot. And then the second patient had said, they hand you the whole thing, and you think you're going to go back and read it, but you don't end up doing that. And 50% of patients had mentioned that it was just too much information that they had gotten. But on the other hand, 5 out of 8 physicians, so 62.5% of physicians, thought that the information provided to patients was complete and easy to understand. And just an example of what one said, we have lots of information, it's usually well understood by people with a high school diploma. So there's kind of a discrepancy there in terms of how the information, what patients felt was adequate information or inadequate, and then how physicians basically presented that information, what they thought of the information that was being given to patients. And then about 20% of patients thought that the amount of detail or information was not adequate. And 37.5% of physicians felt that the information overwhelmed patients. So there is a huge kind of in these two parts. So first, starting with knowledge, mostly what happens is that patients just get too much information, and physicians hand them these packets, and I don't know if necessarily read the packets themselves, but there seems to be too much information, and I think that was something where it really they felt like they didn't really understand what was going on and would prefer to be talked to on their level. And then finally, elicitation of preferences. So 80% of patients wanted patient autonomy. They wanted to be the final decision makers. And for example, I would prefer to know that I'm making the decision. I mean, after all, it's your body, right? So that was something that was said amongst a lot of patients. And about 62.5% of physicians did a pretty good job of incorporating that into the decision-making process. So for example, that oncologist states that I think most of the time it's their decision, give them the data, but in most cases it's their decision. And then another interesting thing we had found was that among patient priorities and concerns, there was really a range. So 55% of patients had mentioned their specific priorities and what they were concerned about. So for the first patient with breast cancer, she says you ought to be talking about your self-image. It changes your whole self-image. And then the 86-year-old patient with pancreatic cancer says, I'm still living, I still move around. I may not do as good as I used to, but I'm still here. So there's a wide range of preferences that patients have, or concerns that patients have. And then about 37.5% of physicians seem to kind of project their own priorities when talking to patients. For example, the oncologist here states, if the choice is you're going to have a wig for a while, but you're going to be around, I'm much more into doing that. So that sort of reflects what that physician's priority is in terms of care, but doesn't necessarily correlate with what a patient's concerns are, given that there is such a range of concerns that patients have. And then finally, another interesting quote was, I try to make it clear what I think my self-quality of life is. I don't want you to be in the hospital all the time having pain, nausea, and vomiting. So sort of, again, describing what they think are priorities for patients. So then getting down to what I thought was the most interesting part of this is that patients really want the physician's recommendation. 75% of patients mentioned things that almost exactly saying, if I was your wife, if I was your daughter, no matter how much information or what you get at the end of the day, what would you do? And that was something that the majority of patients had mentioned. But on the other hand, physicians would provide recommendations, but without doing that in the context of the patient's preferences. And that was about 75% of patients who do that. So for example, the first quote says, I always tell them that this is a standard of care that I'm able to offer. It may not be something that you want, but I think you should go ahead and get a second opinion. So that doesn't really reflect shared decision making or sort of telling them, I think that these are your personal characteristics and maybe this would work for you. This is more of, this is the data and that's what we have. And then the second one says, I always try to stay really objective. It's hard to stay completely objective and take your opinion completely out of decision making, but I follow the data. So it's sort of that discrepancy in there is that's what physicians maybe perceive as shared decision making and that it's supposed to be your decision, but in reality, patients want physicians to make that recommendation, but just in terms of their personal preferences.
Did you know, I mean, don't you think that most of those people then ask their doc, what would you do or not?
I think they do.
And
But I think
don't you think docs then answer?
Yeah, but I think they don't get an adequate response. And
Even to that question?
Yeah,
Really?
yeah. And that's actually what I found across a lot of the patient interviews, is that there was a lot of frustration with that. Is that they just weren't getting the answers that they wanted.
Because, I mean, I'm sure you've come across too, but it really is a very common question.
Right, yeah.
I think sometimes when it's a life-threatening situation, we see this a lot, like for instance in premature infants where we're asked to operate on a throwback disease. I mean, I think I'm honest with them, but I gotta say, if I was truly honest and I was talking to a mom of a 24-week infant, I'd say I would do nothing at all. And I don't think I have a difficult time saying that to a teenage mom, which often these are.
Right.
So
that's, it's like lacking the confidence appropriately lacking the confidence to project your own whatever.
Right, it's a balance, and I'm not sure. I'm actually
it's
not
difficult.
surprised by this.
Yeah, and then then you overthink because we never know what we're going to do until we're actually facing it.
Absolutely, right.
And so it's like you're putting too much on me here. Maybe I'm going to give you the wrong answer.
Yeah, and it's been actually a really hot topic of discussion. I think it was in the New York Times. There was a recent article by a physician on how physicians prefer to die. And,
that was circulated
in one article.
That's right.
Takes that whole point.
And I don't think a lot of that's ever discussed with your patients. That's
And that's what I thought was interesting is that patients definitely get that sense. Yeah, even though we think we're being kind of diplomatic in how, but they definitely get that sense. So in conclusion, there are several communication gaps in cancer care. We identified a lot of themes across patients and physicians, and there's really a lot of potential to impact, improving shared decision-making and facilitating that communication between patients and physicians to really deliver optimal care to patients. And in this particular, what I had presented was that physicians seem to be reluctant to influence a patient's decision with their personal bias and don't provide recommendations in a format that patients want the recommendation in. But that helps to identify targets for intervention to improve, patient assessment of the patient's informational needs, what do they need to know, and how do they need that information delivered to them, and then also how to elicit those preferences from patients and then being able to communicate to them on that level. So in the future, I'm going to continue to do more patient, physician, and caregiver interviews. Now that we have this new questionnaire that I think is pretty easy to use for patients as well, I'm going to start to get more data on that, which I think will be really interesting to correlate with some of the qualitative stuff. And then, like I mentioned, we're getting a lot of multi-institutional involvement.
Are you planning on doing the multi-institutional prior to receiving funding?
I think so. I had talked to Dr. Ronald about it, and I've been talking to people at Hopkins, and basically, whenever they get the IRB ready, they'll send me there to go start doing interviews. So,
And then who would do the interviews?
to start off with, I am, and then I will train people there, and how to.
Oh, that's cool.
Yeah.
That's cool.
Yeah.
So, yeah, because they could probably set up 4 or 5 for you.
Yeah,
At
exactly.
the higher volume place.
Yeah. And so that's basically identify themes for developing interventions. That's where we want to take this. And like I mentioned before, I really didn't want decision aids or anything of that sort. So we're really trying to come up with something that will essentially change practice patterns. And then we're thinking the randomized clinical trial to audio record clinical encounters is sort of a way of doing that, and that's what we proposed in our grant. And Dr. Weil also wanted me to ask if MD Anderson would be interested in participating in the interviews, and so just as a thing to think about.
I mean, the thing about MD Anderson is you would be able to, you really would be able to hone down on one condition, which I think would be very nice.
Yeah.
But that's just going to be networking, with people. Yeah, I mean, it's like, there's, as you know, there's stuff out there on all this stuff. It's just buried in literature that no one reads. And so when docs do it, not that I'm biased in favor of docs, but when docs do it, then we publish in docs. You publish in American Journal of Surgery or whatever it is,
Yeah.
And that's so important in terms of communication.
This literature has been out there for years.
Yeah.
Have you considered engaging LBJ or some of or I know Taylor has contacts. You might capture a different population of patients. You noted that all of your patients are insured. Well, that would be a whole, and I know that Taylor has worked with them on other projects because we're all kind of integrated as surgeons. So
that would
it might be an idea to approach them because they have a totally different patient population than the insured patient population. And their issues with all this may be very different.
Totally. Yeah, I completely agree. And that's I talked to Dr. Weil about that, but I didn't think about Pentalk. We didn't think about
Pentalk or LBJ. I mean, I think that she's done projects in the past with the folks, with the surgical oncologists at LBJ. I might be wrong, but I thought she had.
Yeah, if we could collaborate with them, that would be a really good part.
And
Because we're missing.
it's not as far to travel for you.
Yeah.
Thank you.